morning to all. In today's lecture, we are going to cover the chapter Sedative-Hypnotics. So coming to the outline of this chapter, we are going to cover introduction of sedative hypnotics, the sleep architecture, the stages and the architecture of sleep, then the classification of sedative hypnotics. The first class, that is barbiturates. Under barbiturates, we are going to cover pharmacological actions, mechanism of action, then the pharmacokinetics, uses, interactions, adverse effects, and acute barbiturate poisoning. Next class we are going to cover in this chapter is benzodiazepines. These are also known as BZDs, which is the accepted short form for this particular class. Here we are going to first see the advantages of BZDs over barbiturates. That is how barbiturates have and why the barbiturates have gone out of use actually. What are the advantages of BZDs? Next we are going to cover the pharmacological actions of BZDs, site and mechanism of action, pharmacokinetics, adverse effects and interactions of the benzodiazepines. The next class, that is a newer non-benzodiazepine hypnotics. So this is the recent class which is introduced, and it clearly mentions that these are not similar to benzodiazepine. It's a non-benzodiazepine hypnotics which is recently introduced and it is quite widely used. Next we are going to cover the uses of sedative hypnotics, after which we are going to go into the benzodiazepine antagonists, that is flumazenil. And lastly, there are two small points, that is recently introduced drugs known as melatonin and ramipril. So to start with the introduction of the chapter sedative hypnotics, so first we are going to see the definition, what exactly a sedative is and what exactly a hypnotic means. So coming to the definition of sedative, so it is defined as a drug that subdues the excitement and calms the subject without inducing sleep, though the drowsiness may be produced. So it clearly states that these particular drugs, that is sedatives, they do not induce the sleep. They just induce the drowsiness, and because of which they calm down the person. That is, they control the anxiety. So they are having mainly the anti-anxiety property. Okay, so excitement in the particular person is reduced. So a person's responsiveness towards any kind of stimulation, so this particular responsiveness of that particular person is decreased when the sedative drug is administered to that particular person. Whereas if you consider the definition of hypnotic, it is a drug which induces and or maintains the sleep which is similar to normal arousable sleep. So these are the drugs which are used actually to either induce or to maintain the sleep, or both to induce as well as maintain the sleep. Okay, so the basic difference between these two particular classes is that one particular drug, that is sedative, it just produces the drowsiness or sedation, whereas hypnotic is a drug which can induce the sleep. Okay, now why are we studying these particular drugs together? Now the reason behind why we are studying these drugs together is that the same drug is acting as a sedative and the same drug may also have a hypnotic property. Now this hypnotic property, it should not be confused with the term hypnotism. It is a trance-like state which you all are aware that it is used by the say the doctors or the psychiatrists. They use this particular techniques to talk with the patient, to say draw some information. Even this particular technique is also used to hypnotize the criminals to draw some information. So this hypnotism is different from the hypnotic action. Hypnotic action meaning to induce the sleep. Now as discussed earlier, both these particular drugs have the same properties. Okay, so both of these class of drugs, they are more or less general CNS depressant drug. Only the difference is in the time action relationship or dose action relationship. That is, the same drug in a lower dose may act as a sedative, and the same drug in a higher dose may also have the hypnotic property. That is the reason why we are studying these both drugs in the same chapter. Okay, now which type of drugs you are going to prefer as a sedative, and which are the agents which you are going to prefer as hypnotic. Okay, so now those agents which are having quicker onset of action, that is those drugs which show the action very quickly, okay, instantaneously, those whose duration of action is shorter and the DRCs are steeper. Such particular drugs are preferred as hypnotics, whereas those drugs which are acting slowly, a little bit slowly, and those which are having flatter DRCs are generally preferred as sedatives. Now, what is the meaning of this steeper DRCs and flatter DRCs? So, if you can have a look at this particular figure over here. Okay. Now, this is the figure showing the DRCs of different drugs. Now, if you consider this particular DRC, that is the dose response curve. Okay, that is how much of dose produces how much of action. That you can plot, and you whatever plot you get, that is known as a DRC. Now, if you consider this particular DRC, it is having a steeper slope. Okay, that is a little bit increase in the dose produces higher amount of increase in the response. Whereas if you consider this particular DRC, it is flatter in nature. That is, more amount of drug is required to produce a particular amount of action. So that is the difference between a steeper DRC and a flatter DRC. So those drugs, or those sedative hypnotics, okay, so those drugs which are having steeper DRCs, they are preferably used as hypnotics, that is to induce the sleep, whereas those drugs which are having flatter DRCs, they are preferred as a sedative. However, if you consider the actions as earlier discussed in the first point, that the actions are considerable overlapping. That is, a same drug in a lower dose may show sedative action, and the same drug in the higher doses may have the hypnotic action. And hypnotic drug, when it is given in still higher doses, it can even produce the general anesthesia. Okay, so if you consider the response, it is a graded one. That is, as you increase the dose of that particular drug, the action may change. So, in the lower doses, it may show a sedative action. In the still higher doses, it may produce a hypnotic action, that is, it may induce the sleep. And at a still higher doses, it can also induce the general anesthesia. So, difference may be just with the dose of a particular drug. It is not true for all the drugs, that is, all the drugs may not show all these properties, but mostly if you change the dose, it will show the graded type of action. Now, coming to the next point, that is sleep. So, before going to the drugs which are acting on actually your sleep architecture, that is sedative hypnotic, the drugs which are either producing drowsiness or inducing sleep. Okay, so such drugs are used in the treatment of condition known as insomnia, wherein there is lack of sleep or there is difficulty in falling asleep. So before going to the drugs which are inducing the sleep, let us go into details about what sleep exactly is. So we need to know what is the pattern of sleep, or what is the architecture, basic architecture of the sleep. Now, if you consider sleep in a particular person or in a particular individual, it may not be same. Okay, that is, it may vary from in a same person at different particular times. Not only that, it is variable among different individuals also. That is, the sleep pattern and duration is variable. It is not same for everyone. It may vary from person to person. Even in the same person also, it may vary at different times. The same person also may not have same kind of sleep every day. Now, there are several factors which are affecting the pattern and the duration of sleep. Now, some of the factors include the age. This is a very important fact. That is, as the age progresses, not only the duration of sleep, but the pattern of sleep also changes. The depth of sleep also will change. As you all are aware that the small babies, they sleep for a longer period of time. So as that baby grows, the amount of sleep may not remain the same. As the age progresses, the amount of sleep also go on reducing. Okay, so age is a very important factor. Apart from this, there may be several other reasons. Like, for example, if you consider a person who is mentally ill, who is suffering from some kind of psychological disorder, may not be able to sleep appropriately. Say, consider depression. The person may not be able to sleep appropriately. Apart from that, if the person is suffering from some kind of physical illness, okay, some kind of chronic disease or chronic illness which is quite painful, which may produce breathing difficulties if the person goes to sleep. So under such conditions also, the person may not be able to sleep appropriately. Okay, so sleep pattern is totally different for different individuals, even within the individual at different times, and also there are several factors which are affecting the amount and the depth of the sleep. Okay, now coming to the sleep architecture. Now if you consider the sleep architecture or the pattern of sleep, it is a cyclic process. That is, there are several stages in the sleep. These occur in succession, and after one cycle is completed, the same cycle is repeated over a period of time, and then again the same cycle keeps on repeating. So we will go into what exactly these stages are and how exactly they are repeated cyclically. So if we have a look at this particular figure, this shows the time in hours, okay, for which you sleep. That is, it is considering say 7 hours sleep. So 23, that indicates the 11 p.m. So the person going to sleep at 11 p.m. and wakes up at 6 a.m. in the morning. So what is the type of pattern of sleep which is shown by this particular person throughout the sleep? So that is discussed in this particular figure. Okay, so if you consider this particular vertical column, it shows the various stages. Okay, so first one is stage 0, then stage 1, stage 2, stage 3 and stage 4. So there are 4 main stages, and these 5 main stages, and these 5 stages collectively, they are given a term known as NREM sleep or non-REM sleep, all these stages together. And there is one more type of sleep known as the REM sleep, okay, which is indicated by this color. If you can see over here, it is interspersed in between. Okay, so if you consider that a person goes to bed at 11 p.m., firstly the person is in stage 0, after which the person slowly, as the time elapses, the person slowly goes into stage 1. Here the person will spend some time in stage 1, after which the person may go into stage 2, then stage 3, then stage 4, and after stage 4 the person goes into the REM sleep, say around about half an hour or something like that. Okay, so this completes the first cycle of sleep, and roughly it takes round about 80 to 100 minutes for a person to complete this one cycle of sleep. Now after REM sleep, again the person goes into stage 1, after which the person may go into stage 2, 3, again stage 4 and back into the REM sleep for some time. Okay, so this completes the second cycle. Again the person will go into stage 1, stage 2 and stage 3. Now the depth of the sleep is going on reducing. As the time elapses, the depth of sleep also is going on reducing. So here the person goes up to stage 3, again into REM sleep, again stage 1, then 2. Okay, so here the person is not going to stage 3. Then again REM sleep, then stage 1, stage 2, and then slowly the person goes into stage 1 and again back into stage 0. So once the person comes back to stage 0, that means the person is awake. So the person wakes up. Okay, so in the meantime, sometimes the person may also introduce night awakenings, that is nocturnal awakenings, meaning the person may go into stage 0 in between. Okay, so that is known as nocturnal awakening. So rather than passing from REM sleep, rather than passing into stage 1, the person may sometimes go into stage 0, so the person may wake up in between also. So these intermediate awakenings may also be reduced by the sedative hypnotic drugs. Okay, so this is the basic architecture of sleep. Now we shall discuss the characteristics of these individual stages also in detail. Like what exactly is happening, how your brain is showing the activity, how much time is spent in each particular stage, what is happening to the eye movements, what is happening to the muscles, what is happening to the other modalities like your heart rate, blood pressure or your respiration. Okay, so all these details we are going to see individually under each stage. Now coming to the first stage, that is stage 0. Okay, is this particular stage is also known as awake. Okay, now awake meaning although you lie down, although you go to bed, it's not that immediately you will fall asleep. So there is some time lag in between you falling asleep, okay, lying down and falling asleep. Okay, so this stage 0 indicates the time from lying down to time taken to fall asleep. Not only this, it also includes the intermittent nocturnal awakening which I was talking about. Okay, so sometimes a person may wake up at night in between. Okay, so those particular night awakenings are also considered under stage 0. Okay, that is awake. Now the total time of sleep which is spent in this particular stage is just 1 to 2% of the total sleep time. If you consider the EEG, that is electroencephalogram. Now over here the activity of the brain is checked by the EEG. So activity of the brain varies in different stages. Now if you consider stage 0, over here also the activity of your brain depends upon whether your eyes are open or whether they are closed. You are awake, but sometimes you may close the eyes and sometimes you may open the eyes. So depending upon whether your eyes are open or whether your eyes are closed, the brain activity varies. So now when the eyes are closed, alpha activity is seen in the EEG, whereas beta activity is seen when the eyes are open. Coming to the eye movements, there are irregular or slowly rolling eye movements. Okay. Then next coming to the stage 1, this is also known as dozing. Now over here if you consider the EEG, alpha activity, it is interspersed in between the theta waves. So theta waves are also seen over here. Eye movements, these are reduced as compared to stage 0, but sometimes intermittent bursting of rolling eye movements may take place. Neck muscles, if you consider, they are totally relaxed over here, and the total time which is spent in this particular stage is 3 to 6%. Next, moving on to the third stage, that is stage 2. This is also known as unequivocal sleep. Over here the EEG shows theta waves interspersed with the spindles, and kappa complexes, this can be evoked only upon the sensory stimulation. Like if you touch that particular person or if you try to move that particular person, then the kappa complexes will be evoked. Eye movements are still reduced and the subject or the person is easily arousable. You can wake up that particular person very easily, and the total time spent in this particular stage is 40 to 50%. Now the fourth stage is stage 3, which is also known as deep sleep transition. Over here the EEG, it shows theta activity, then the delta waves, and also the spindle activity. Kappa complexes, this can be evoked only upon strong stimuli. Suddenly if you start shaking that person very vigorously, then and only then the kappa complexes can be seen in the EEG or recorded in the EEG. If you consider the eye movements, these are very few and the subject is not easily arousable. You cannot wake up that person very easily from the stage 3, and the total time spent in this stage is 5 to 8%. Then the fifth stage is stage 4, This is also known as cerebral sleep. Over here, in case of EEG, the delta activities are quite prominent and kappa complexes cannot be evolved. Okay, you cannot evoke the kappa complexes in that particular person's brain activity. Then coming to the eye movements, the eyes are practically fixed. There is no eye movements and it is very difficult to arouse the person. And nightmares or night terrors, that is the bad dreams which are seen at times. So these occur mainly in stage 4. Now, if you consider there are some common points, that is if you consider stage 2, 3 and 4, over here the heart rate, BP and respiration, all these modalities are steady. Okay, they are not fluctuating, they are normal. Muscles are completely relaxed. And stage 3 and stage 4 together, taken together, stage 3 and stage 4 taken together, these are also known as slow wave sleep or SWS, the accepted short form. Then, so these 5 stages are included under the NREM sleep. Now coming to the REM sleep. So after stage 0, 1, 2, 3, 4, the person goes into the REM sleep. Now this REM sleep is also known as paradoxical sleep. Now over here the EEG has waves of all the frequencies. All the waves are seen in the EEG. But kappa complexes cannot be elicited. No kappa complexes will be seen in the EEG of that particular person. If you consider the eye movements, there are marked, irregular and darting eye movements. Okay, eyes are rapidly moving and irregularly they are moving. Okay, dreams and nightmares also occur in this particular stage, and when the person wakes up from this particular stage, then the person can even recall what type of or what dreams has been seen by that particular person. If you consider the heart rate and the BP, these are fluctuating. Even the respiration also becomes irregular in the REM sleep. Muscles are totally relaxed, they are fully relaxed, but sometimes irregular body movements may be seen. In case of males, sometimes erection, penile erection may also take place. And the total time spent in this particular stage is 20 to 30%. So if you consider overall sleep, the person normally goes from stage 0 to 1 to 3, 2, 3, 4 and then the person goes into REM sleep. So this takes around about 80 to 100 minutes. And after this, the person goes back into stage 1, then stage 2, 3 and 4 and again into REM sleep. And all these stages in succession, these are repeated cyclically. Now coming to the classification of sedative hypnotics, the first class under this chapter is barbiturates. Now again, these barbiturates are sub-classified. Now this sub-classification, it depends upon the duration of action. So whether the drug is long-acting, the short-acting or ultra-short-acting. So long-acting drugs, the example includes phenobarbital. The drugs which are short-acting includes butobarbitone and pentobarbital, and the ultra-short-acting drugs include thiopentone and methotrexate. Then the second class includes benzodiazepines. So here if you see there is again sub-classification, but the sub-classification is not based on the duration of action, but it is based on the use of that particular drug. That is hypnotic or anti-anxiety, or there is a third sub-classification, that is anticonvulsant. So here the sub-classification is based upon the use of that particular drug. And because of this, the same drug may also have multiple properties. So because of this, the same drug may be repeated. Okay, like if you can see here, diazepam is included under both the subclasses. Even alprazolam can be seen in both the sub-classifications, because both the drugs have hypnotic property also and they are having anti-anxiety property also. Okay, so considering the first subclass, that is hypnotic benzodiazepines, the examples are diazepam, flurazepam, nitrazepam, alprazolam, temazepam and triazolam. The next subclass is anti-anxiety. Here the examples are diazepam, chlordiazepoxide, oxazepam, lorazepam and alprazolam. Then the third sub-classification under benzodiazepines include diazepam. Again, diazepam is also having anticonvulsant property, lorazepam, clonazepam and clobazam. So this is to do with the benzodiazepines. Now why it is subclassified depending upon the actions is they are not general CNS depressant drug, but they act at different facets, okay, in the CNS. They have specific type of action or specific mechanism of action. They act at different areas and produce different type of action. That's why same drug is also having multiple properties. Then the third main class under benzodiazepines include newer non-benzodiazepine hypnotics. Okay, so as the name implies, this is a recently developed class of drug and it is not related to the benzodiazepine class. So it's a newer class. Mechanism of action is similar to that of benzodiazepines, but they are not chemically related to the benzodiazepines. There are three examples over here: zopiclone, zolpidem and xanilone. This finishes the classification